This is TTT Live. I'm Mahalia Joseph Wharton. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, Suite 100.1 FM, Next 99.1 FM, and on Facebook at TTT Live Online. We go now to Senior Corporate Communications Officer at the Ministry of Health, Al Alexander.
Good morning and welcome to another edition of the Ministry of Health Virtual Media Conference, where we provide the public with current and accurate information on the Ministry's COVID-19 response. Today in studio, we have Dr. Miriam Richards, Principal Medical Officer Institutions, Dr. Avery Hines, Technical Director, Epidemiology Division, Ministry of Health, and Professor Christine Carrington, Professor of Molecular Genetics and Virology at the University of the West Indies, St. Augustine's Faculty of Medical Sciences. I am Al Alexander, Senior Corporate Communications Officer at the Ministry of Health, and I will moderate this morning's media conference. We begin with Dr. Richards, who will provide the clinical update and the latest on the parallel healthcare system and repatriations. Dr. Richards.
Thank you very much, Al. Good morning to Mr. Alexander, my colleague Dr. Hines, and Dr. Carrington, our counterparts from the University of the West Indies. Good morning to members of the media, the Ministry of Health, and the government of Trinidad and Tobago. Really appreciate your support as you continue to provide transparent and real-time information to our people of Trinidad and Tobago. Good morning to the listening population of Trinidad and Tobago and those who are viewing on social media and other media. This morning, I will be providing an update on the parallel healthcare system, as well as an update on the repatriation process that is ongoing in an effort to return our nationals in a safe and effective manner. I'll start with the clinical status update as per Media Release 714, and which was done up until and provides figures up until 4 p.m. yesterday. At present, there were 235 confirmed cases of COVID-19 that were reflective of samples that were done between the 1st and 3rd of May 2021. This takes the total number of active cases to 2,689. At present, these positive cases are divided as follows: 264 patients in the hospital, with admissions pending at this point in time and as of 9 a.m. this morning for approximately 42 patients. The total number of patients in our step-down facilities, which is 36, and 227 patients in state quarantine facilities. We have 2,154 persons who are in home isolation and are being managed by the relevant county medical officers of health with support from the Ministry of Health. Unfortunately, we have had 185 deaths so far. And I'd like to pause and inform the public about the change in the mortality or pattern as it pertains to deaths. We have been noticing a very disturbing and concerning trend with regards to the mortality or deaths of patients. We are no longer just seeing deaths amongst the elderly population and persons with coexisting medical conditions, but we are seeing deaths amongst persons even in the age group of the 30s. This emphasizes the need for members of the population and, our Trinidad and Tobago to really start adhering to the public health prevention methods. We noticed from February of this year an increasing trend in terms of the number of cases. My colleague, Dr. Hines, repeatedly in conferences done with the Honorable Prime Minister and on this forum noted the increases in the rolling average in terms of the number of patients that have COVID-19 or persons who were diagnosed as positive. There's been a continuous emphasis on hospital occupancy, and there has been an increasing trend with respect to hospital occupancy that again is very concerning. On the 3rd, our overall hospital occupancy was 48%. On the 4th of May, we saw an increase to 50%. And yesterday afternoon, we had an increase of 58%. So we've seen a 2% increase and then an 8% increase. And these increases are in spite of measures to increase the capacity of hospital beds. Our ward occupancy rates have increased within 24 hours from 50 to 60%, which is a 10% increase. And our ICU occupancy rates have decreased from 50% to 40%. I'd like to reiterate that the decrease in ICU rates is not due to the discharge of patients or the step down, but unfortunately due to the death of patients. And yet again, I would like to emphasize, as I did in previous conferences, that the clinical pattern or the clinical course of patients, that is how patients are treated in the hospital and the severity of their condition, has become worse. We have seen now a trend in which persons with mild illness are really being hospitalized, or less critical illness, are being hospitalized for up to 5 days, somewhere between the range of 3 and 5 days. And we are seeing that also persons presenting, for example, to the Couva Medical and Multi-Training Facility and to the Scarborough General Hospital are even more ill and are requiring ICU and HDU care. These persons are required to stay in hospital for anywhere between 12 and 21 days, according to our latest statistics from May 1st. This is representative in terms of the high dependency unit occupancy, which has increased overnight from 40% to 70%. Now, I'd like to express what's the current status in terms of a supply-demand equation. The supply for hospital beds, the demand for hospital beds has been increasing. Now, there are limited resources in terms of the hospital beds. And I'd like to again remind the population, as I did on Monday, that a bed is not merely a bed. A bed consists of the nurses, the doctors, the supporting staff, for example, lab services that have to do laboratory tests on a daily basis, the provision of personal protective equipment, for example, the Tyvek suits that you see nurses in, the face masks, etc. And globally, there is a supply-demand challenge in terms of this sort of PPE. Additionally, limiting factors include the medication to treat these patients. Again, there's a global supply-demand challenge for the receipt of this sort of medication regionally and locally, as well as even the ambulance services. We do not want to overwhelm our ambulance services. If you have a relative or if you yourself require hospitalization for a condition like a heart attack, we would not want the ambulance services to be overwhelmed by transporting COVID-19 patients. So again, I would like to remind the population that a bed is not simply a bed. At the Ministry of Health, over the last few days, and specifically effective the 1st of May, we activated an additional 115 beds. And we transitioned one of our hospitals, which is the Augustus Long Hospital, from a suspected cases hospital to a confirmed case hospital. We are imploring the population to decrease this demand for beds by basically adhering to public health interventions. Now, I know that over the last 3 days, there's been a focus in terms of hospital occupancy levels and a concern about the number of days that we will have hospital beds for. Just to give you an update about this sort of concerning pattern, there are currently 542 beds available with supporting staff. And if all things are equal, meaning that our staff continues at the numbers that they are continuing, that we have all the equipment in place, supportive and otherwise, that our ambulance system is not overwhelmed, which we were close to, I must say, on Thursday night, we will have only 226 spaces available, which gives us 7 days to full occupancy. As of 9 a.m. this morning, there are 316 patients in hospital, and this represents a significant increase from the 264 patients. As I indicated previously, 14% of persons who are confirmed as COVID positive require treatment in a hospital center. Only 6% of those persons are discharged on a daily basis. And I'd like to bring the point of the gravity of the situation in terms of the number of days that someone stays in hospital. It's not a 2-day turnaround. It can be anywhere between 5 days and 21 days, sometimes even longer. At this current rate, and given our hospital occupancy levels, we will run out of hospital beds or use all our hospital beds within 7 days. And this really defeats the purpose of the parallel healthcare system. The parallel healthcare system was instituted on March 12, 2021, with 2 beds at the Cora Hospital, and has now increased to 1,700 beds. However, 542 of those beds are dedicated to the treatment and the medical management of ill COVID-19 patients. Of course, we continue to have our quarantine sites as well as our step-down facilities that account for the remaining, on average, 1,200 bed spaces. The management of COVID-19 is not merely a treatment aspect. It's actually a 2-pronged approach, which involves the public health measures. Now, I'd like to stress that the behavior of the population and the public health measures fall outside of the remit of the Ministry of Health. On the media on Monday evening, we were very concerned about scenes on Areopita Avenue where there was congregation of persons, the improper use of face masks, and this was aired on mainstream media. This is not hearsay. We would like to implore, I am begging, on behalf of the government, on behalf of all frontline workers who have been working tirelessly since February of last year, on behalf of the Ministry of Health and the Ministry of National Security in particular, for all members of the population, to please adhere to the COVID-19 mitigation measures, COVID-19 prevention measures. Please, let's avoid commingling. Commingling right now, congregating, are the dirtiest words in the health sector right now and in public health. Because the mixing of persons, the commingling of persons, the congregation of persons, whatever term we would like to describe, continues to be the main factor, the main risk factor in the spread of COVID-19. Young people, we are seeing deaths, and sudden deaths, from the 30s onward. Please don't think you are immune. Please, this concept of a bubble that I've been hearing touted around does not work. Different persons from different households carry different exposure risks. So by you saying that you would be liming or zessing or wessing or whatever term you want to use with persons, the same group of persons, while you are interacting with persons at the supermarket or at your workplace, it means that you have a different level of exposure. Young people tend to have mild or no symptoms, so you could be a carrier of COVID-19, and you will take this to your friend's home and to your friend's parents' home. Let's please avoid this congregation and commingling or gathering of persons. Let's, when we go to the supermarket, when we go to an essential services area, be it a hardware or somewhere to have our car repaired, let's avoid the close lines. Let's wear our masks properly and social distance. And let's continue to sanitize and to wash our hands. We also need to remember that if we are ill, please stay at home and isolate yourself. contact the Ministry of Health, 877-WELL, 800-WELL. You need to be tested. The Ministry of Health continues to attempt to do contact tracing. And the more cases that we get with respect to contact tracing, with respect to COVID-19 and confirmed cases, means that we have to contact trace even more. I'm appealing to members of the population to reach to at least resolve the equation with respect to supply and demand. COVID-19 is the great equalizer. It affects families, persons, workplaces, irrespective of social class, irrespective of your education. And it is treated at in the parallel system, which is currently under strain. I'd like to reiterate, we have 7 days to go. And I'm asking the population to continue prevention of COVID-19. I'm asking everyone to stop the commingling, stop the mixing of persons. It's becoming overburdening to our health system, and it may impact on the treatment of your relatives. Please note, and again, I'm just sharing with you what's going on in the health center from the health sector, from a transparent perspective. It's the same frontline staff, doctors, nurses, TTDF, and others who have been managing the parallel healthcare system since February last year. They've been managing the repatriation process for the return of our relatives. They've been managing the vaccination process, right? And we're seeing upwards of 4,000 vaccinations being done a daily across 29 centers. They are managing the process with respect to the treatment of patients, the quarantine centers. It's the same staff. We have limited resources, and we are asking you, with respect to the public health measures, which we put in place since April of this year, because we saw the increase in the number of cases. We were proactive. We were trying. Dr. Hines kept emphasizing the increasing numbers. I myself spoke about the increasing hospital occupancy, which was worrisome, starting at 2% somewhere at around week 11 and inching up every week. I'd like to also have a short discussion on the repatriation process. The government of Trinidad and Tobago, and the Ministry of National Security in particular, wants to bring your family members home in a safe and effective manner. We understand and appreciate your cooperation and your patience. This evening, we have a repatriation flight from Canada with approximately 89 persons. On May 7th, we have a repatriation flight from Barbados, in which we have given approval to 120 persons, with an emphasis on students who need to return home. On May 15th, we have a repatriation flight from Miami with 140 persons. We continue to try to keep your families safe. We continue to try with respect to limited staffing resources and other resources that are required across the parallel healthcare system. As I close today, I want to discuss with you, I want to share with you Mother's Day. We would not want to lose our mothers, our sisters, and our daughters prior to Mother's Day. And given the trend of persons being hospitalized and persons who are dying on a daily basis, we need to have a personal responsibility and be vigilant. Let us be our relatives' keeper. Let us be our neighbors' keeper and our co-workers. Let us please practice those 3 W's that we have been speaking about since February of last year. Let's watch our distance and avoid the commingling and the congregation and the mixing of persons. Let's stop this concept of a bubble. It is risky and of high exposure. We appreciate your patience. We understand the challenges which you have socially, mentally, and we know that it has not been easy for any of us. Let's wash our hands and let's wear our masks properly. Let's continue to rally around our Ministry of Health, the Ministry of National Security, the Ministry of Social Development, and the Airports Authority, Civil Aviation, and all other persons, including those in the energy sector, that continue to rally around and to fight this war against COVID-19. Trinidad and Tobago, we need your support at this point in time. We need your assistance. Let's protect our population and let's continue to be safe. Thank you.
A very strong plea and sobering advice by Dr. Richards. Thank you very much. I now invite Dr. Avery Hines to deliver today's epidemiological update. Dr. Hines.
Okay, thank you, Mr. Alexander. Good morning to my colleague, Dr. Richards, Professor Carrington, members of the media, members of the viewing and listening public. If I can have the first slide, I'm going to go quickly into the epidemiologic update. As we have been emphasizing, we are seeing, please remove the bottom third, the upward trend of taller and taller bars on the right-hand side of this graph. Those purple bars representing the cases in April, and the comparison between the height of those and the height of the gray bars on the left, where the tallest ones there represented September, shows the number of cases that we're seeing on a daily basis compared with last year during the last peak. And we see that this peak is definitely higher, and that our rolling average, that dotted line running through the graph, continues to increase. Next slide, please. Looking at that on a week-to-week basis, we see basically the same thing, where the bars now represent 1 week's worth of data. And from about week 10, we've seen that upward trend, the bars getting taller and taller. And around that time, we began to emphasize that we were seeing the upward trend, looking at moving from the relaxation of the sporting measures back to restricting those again. And then as numbers continue to increase, implementing progressively more stringent measures to reduce the possibility of people moving around and interacting, with measures being implemented on the 14th of April, the 22nd, the 29th, and then again on May 3rd. Next slide, please. Looking at this is the overall general population pyramid for the COVID cases, the positives, where we see that approximately 52% of the cases were male and 48 just about percent of the cases were female, and the majority of them in that 25 to 29 age group. That's from the start of the first big peak in July all the way through to now. However, let's move to the next slide. If we look at just the cases for April, from April 1st to April 30th, we see just about the same kind of distribution by age, but a little more of a female preponderance. So now it's nearly 50-50, just looking at that April group, which is a large group by itself. Just about 50% male, 50% female, more or less, with the same age groups being affected. In fact, slightly more people in that 25 to 49 year age group. Next slide. Now, looking at the deaths just in the last week or so, from last week Sunday, not this Sunday gone, April 25th, through to May 4th, where we saw about 26 deaths take place, what we're seeing here is two things that are of some concern. One is that there are more women proportionally than we were seeing before, whereas we were seeing the sort of 1/4 of the patients who are passing on being women and 3/4 being men. Here we can see where it's nearly half and half. 46% of them are women, and we're seeing a slightly higher proportion in that younger age group. And as Dr. Richards emphasized, some of these people had no comorbidities. So again, this is something that we've said before, but we're re-emphasizing it. Yes, comorbidities are common among those who pass on, but they aren't required in order to have a negative outcome. So no one should take it for granted that if they get COVID, they'll be okay. Next slide, please. Looking at the overall death pyramid and that pie chart, what we see is the effect of those two things. Slightly more women, an increasing proportion of women, whereas we were seeing 75-25 men to women, now we're seeing 72-28. So that proportion of women is increasing, and the number of people in that under 40 age group has also increased. Next slide. Now, this is just looking at the genders across the counties, and we see largely 50-50, but in some counties slightly more women. And it's just, again, reflecting what we were seeing. This is over the last 2 weeks or so. So more women being affected, and that's reflecting itself in some of the mortality stats. Next slide. This is just the representation, again, of that upward trend from 1 week to the next in each of the counties. Next slide. And This is week 16, yellow dots being new cases. Next slide. Week 17, which is the week we just completed, the new yellow dots are new cases for week 17. So the older yellow dots from the previous slide would actually have been turned purple. So we're adding basically this group on top of the group you just saw. So you're seeing the large numbers of cases accumulating in that last 2-week period. Now, if we resolve that into equal sort of geographic areas, next slide, we see that the density of the cases where the darkest hexagons are, we're seeing that distributed in that St. George West area all the way through the East-West corridor, into Carrington, some parts of Victoria, some parts of St. Patrick, and also the urbanized areas in both St. Andrew, St. David, that's over by Sangre Grande side, and the River Mayaro, Rio Claro. Next slide. If we look at that on a community basis, we see where those dark red colors now represent even larger numbers of cases in communities, again with that distribution that we described earlier. Now, I want to recap something that we spoke about on Monday. Next slide, please, where we were looking at that hospital occupancy and active case projection. Next slide. What you would have seen there was something that we got some feedback was maybe a little confusing to the viewing audience because they can't see the axes. But this graph had 2 y-axes. One, I think we're going to need to move the sign language square over to the left. One that actually was on the right-hand side for bigger numbers, and the second on the left-hand side for the smaller numbers. So the active cases were up at 2,500, and that was being read off the axis on the right. We've decided to simplify that, next slide, by putting everything onto one axis. But when you do that, what you see is that the actual active cases, they show a much higher number, they're much taller, and the new cases and hospitalizations then look kind of small or short or flat on the graph. So the trend was a little harder to appreciate. Nonetheless, this is what it looks like when you're comparing everything on the same scale. Next slide. If we just look at the projections of those active cases, we see where that projection runs up to getting towards 10,000 people by the end of May, which is not a place you want to be. Next slide. And for the projected hospitalizations, we're seeing where that line representing the 542 cases of 542 beds is going to meet the projection line with the blue dots around the 13th or so of May, and we do need to flatten this curve. When we speak about flattening the curve, this is what we're talking about. In order to prevent this rate of hospitalization from maxing out bed capacity, we have to reduce the numbers of active cases, which means we have to reduce the number of new cases. Next slide, please. When we put all of that together, what we see is we're projecting obscene numbers of active cases and of new cases moving forward, that light green area. You're seeing numbers that we definitely don't want to see pop up into the health system, and that red dotted line, the same maximum hospital capacity, now is a little lower down on the graph because we're using the same scale with the same intersection point around May 13th. Next slide. If you add on top of that the projected active cases, you see everything on the same scale, but because the lines looked quite flat and hard to appreciate, last slide, we actually put those onto 2 separate axes so you can read the hospital capacity and hospital occupancy off the right-hand axis, and the projected numbers of cases, whether active or new, off the left-hand axis. So hopefully that made the graphs that we shared on Monday a little easier to appreciate. I'm going to wrap it up there just with the reminder that in order to flatten these curves, each of them, the new cases, the projected active cases, the projected hospitalizations, the adherence to keeping away from each other and out of circulation at this point in time when there's a high level of viral circulation and prevalence in the population, the imperative nature of that stay away, the importance of not circulating, of finding ways to work remotely, of finding ways not to interact as much, is the only thing that's going to drive those numbers downwards. So with that, I'm going to turn you back over to Mr. Alexander.
Thank you very much, Dr. Hines. We welcome back Professor Christine Carrington from the University of the West Indies. Last month, she provided us with some statistics on We welcome back Professor Christine Carrington from the University of the West Indies. Last month, she provided us with some very interesting details on the P1 COVID-19 variant. So today, she is here to share further updates. Professor Carrington.
Thank you, Mr. Alexander, and good morning to my colleagues, Drs. Hines and Dr. Richards. And good morning, of course, to the listening and viewing public. Now, over the past year and a half, at least 153 million people around the world have been infected with the COVID-19 virus, SARS-CoV-2. And every time that virus infects an individual, it replicates to produce millions and millions and millions of new viral particles. Occasionally, during that copying process, you get errors that are made, and those errors are called mutations. Now, this, as I've said before, the appearance of mutations is normal, it's expected, it is the way that the virus evolves into many different lineages, okay? So slightly different versions of the virus that you can distinguish from each other on the basis of those mutations. Now, sometimes those variants are referred to as, those lineages are referred to as variants of the original virus. Now, the vast majority of mutations that occur, as I've mentioned before, they have no effect on the virus's ability to cause infection or disease. However, occasionally you do get mutations that change the virus's properties. So, for example, they might change the transmissibility of the virus, they might change its ability to cause more severe disease, or they might affect the way that it responds to the immune system. So it might be, for example, less easily neutralized by an immune response that was produced against a previous lineage. So in my lab at the University of the West Indies, and I want to call their names because of the work that they've been doing, Dr. Nikita Sahadeo and Mr. Vernie Ramkisoon have been hard at work using a technique called nanopore sequencing to determine which lineages and variants of SARS-CoV-2 have been circulating in Trinidad and Tobago and in the rest of the Caribbean. Now, this work is being done under a project called COVID-19 Impact, which is a UE-led project in collaboration with CARFA, the Trinidad and Tobago Ministry of Health, and the Universities of London and University of Oxford. Now, can I have my first slide, please? Right. To date, we have received 667 samples from 17 CARFA member states, including Trinidad and Tobago. And of these, 635 were suitable for sequencing, and 560, to date, 561 have been sequenced of those. And in terms of variants of concern, we have detected in the Caribbean, this is the whole Caribbean, B117, which was first identified in the UK in 15% of the samples, P1, which was first identified in Brazil in 6% of the samples, less than 1% actually had the variant B1427 or B1429, and those were first identified in California. And then the vast majority belong to a variety of other lineages. Okay, next slide. So for next slide, please. So for Trinidad and Tobago, to date, we have received 476 samples for sequencing. And of these, 375 have been sequenced. Can I get the next slide, please? So of those 375 have been sequenced, 74 are currently in process, and 27 were unsuitable for sequencing. And of the 375 sequenced from Trinidad and Tobago, to date, about 10% are of the P1 variant, which, as I said, was first detected in Brazil, and as you are aware, was first detected in Trinidad about 2 weeks ago. I should emphasize that the P1 is the first variant of concern to have been detected in the general population in Trinidad and Tobago. We did detect B117, the UK variant, but that was not in community samples. Now, it's important to note that those percentages that I showed are not, the samples that we get are not representative of all the cases in Trinidad and Tobago. So it's not a random sample. So those percentages I showed do not indicate the prevalence of the variants in in Trinidad and Tobago. So why are we concerned about this P1 variant? Why is it a variant of concern? There's a number of reasons. The first is, the main concern is that it contains a large number of mutations, including mutations in a part of the virus called the spike protein. And that spike protein is a major target for the protective immune response and also the protein around which the various COVID-19 vaccines were designed. Laboratory tests have shown that because of these mutations, the P1 variant is less easily neutralized by antibodies produced in response to infections with non-P1 viruses, which seems to explain why it is able to reinfect people who were previously infected with non-P1 variants. However, important to note, the loss in reduction of neutralization is not 100%. There is still some level of neutralization of this virus by the immune response. And when it comes to the vaccines, while some vaccines may be less effective against P1, a recent scientific article, for example, this one is not yet peer-reviewed, showed very good evidence that antibodies from people who received the Oxford AstraZeneca vaccine and also those who received the mRNA vaccines, they were able to effectively neutralize P1. Also, another study, which again is yet to be peer-reviewed, that study found that in Brazil, where the P1 variant is very prevalent, the mortality rates among the elderly, they rapidly declined following the initiation of their vaccination program. And the vaccination program targeted the elderly first, and it was using the Sinovac and AstraZeneca vaccines. So even in populations where P1 is in circulation, the AstraZeneca vaccine and other vaccines are expected to offer protection, in particular against severe disease, hospitalization, and death. The other concern about P1 that people have raised is a concern about the fact that it may be more transmissible. So there's a major study published in the journal Science, and they found that the P1 lineage, it replicates you tend to find higher levels of virus in people who are infected with P1, and that was in Brazil. And also they found that in Brazil, they estimated that the transmissibility was between 1.7 and 2.4 times higher than the non-P1 viruses. Now what that means is that if you had a person who, if every infected individual was infecting 2 people before, then a person with P1 would infect on average 4 to 5 people. So instead of numbers going from 2 to 4 to 8 to 16, if that one person infects 4 people, you then have the increase going 4, 16, 64. So it's a much steeper exponential rise. It's important to note, however, that the authors of that study cautioned that their results were not generalizable to other settings, so it's still uncertainty about the extent to which P1 is more transmissible, and more studies are needed. The next claim that about P1 is based on observations in Brazil, where this one study, again not yet peer-reviewed, saw 10 to 80%, suggested that it was 10 to 80% more lethal. So what that means is that for every 10 persons that a non-P1-like virus would have killed, P1, according to their study, would be expected to kill 11 to 18 people. However, I think the jury is still out on this because the rise in P1 in Brazil came at a time when the hospitals were being overwhelmed. So it is possible that the increase in deaths that they saw had more to do with inadequate health care than the virus itself. It could also be a combination of the two, so again, more research is needed. To end, I just want to emphasize that all SARS-CoV-2 lineages, all variants are deadly. The variants of concern, the variants of interest, the ones we're not even looking at closely, they're all deadly. These variants started emerging in about December, and we all know how many people died over 2020. So while now public health responses can be informed by, and they may be modified based on the nature of the variants in circulation, it's important from a public health perspective to know what is going on because there are potential impacts. For an individual, the way to protect yourself as an individual remains exactly the same as before. Wear your mask properly, wear it all the time. Once you're not by yourself, wear your mask. Watch your distance, wash your hands, stay at home when you're unwell, and get vaccinated. Thank you.
And thank you, Professor Carrington. As we begin our question and answer segment, The media representatives are reminded to begin by stating your name and the name of the media house that you represent before putting forward your questions to our panelists. In order for us to get the most out of this segment and to allow as many persons to participate, we request a maximum of 2 questions per media house in the first instance. As you know, if time allows, we will allow 1 additional question from media personnel. We begin with CL Communications. Good morning.
Good morning, Natalie Singh, CL Communications. I was just wondering, we have seen supermarkets selling food and they were prohibited from doing so. Is this a permanent fixture now to the regulations that supermarkets are not allowed to sell food? And then secondly, if a person wants to walk in like a nearby savannah, does the regulations allow this? Can you please address this as well as the restrictions for the hotels and guest houses as well? Thank you.
Thank you very much. Dr. Richards?
Thank you, Miss Natalie Singh, for this question. I'd just like to stress that as per the amendments in the public health regulations, effective May 3rd, 2021, there has been no restriction regarding the continued sale of food at supermarkets, bakeries, or vegetable stalls. So I'd like to correct that if there was a miscommunication or some sort of misconception that was being communicated to members of the population. Just to reiterate, as of Thursday, 29, 2021, and based on the data, because the Ministry of Health and the government is guided by the science and data and statistics regarding the COVID-19 pandemic. And as per the Honorable Prime Minister's announcements, I'd like to remind you of the regulations which were put in place. And those were, as of April 29th, the closure of bars and restaurants, the closure of malls, closure of places of worship, the closure of gyms and fitness centers, the closure of spas and beauty service, casinos, cinemas and theaters are now closed, and the closure of all boat tours. The public service was asked to operate on an essential services only, and those are persons who were required to continue with respect to maintaining the organs of the state, and there was a limited flight schedule between Trinidad and Tobago. Furthermore, on May 3rd, 2021, and cognizant of the rapid increase in cases and the strain on the parallel healthcare system, as well as other factors, the Honorable Prime Minister amended that all food services and non-essential retail businesses, and here we were speaking about itinerant vendors, where we saw the long lines, where we saw the improper use of masks. This is public information. This is not hearsay. And we saw it on the media with a lot of citizens being concerned. That was discontinued until May 23, 2021. However, I'd like to state, as per the public health regulations, all essential businesses, groceries, pharmacies, hardware stores, and supporting services continue to operate, but on a limited time schedule between 6 a.m. and 8 p.m. There was also the support in terms of a social safety net for persons who may have been disadvantaged by the closure of businesses. And we'd like to thank the Ministry of Social Development and the Cabinet for that provision. Now, these measures were put in place to once again avoid congregation, avoid commingling, and avoid the mixing of personnel. And we really would like to thank the population for their support and patience, but let's avoid the commingling at the supermarkets and at these places. These are not social places. Don't go with your friend to the supermarket. Don't go with your elderly relative who does not live in the same home. You are making these persons, in effect, primary contacts. Let's consider that we are all COVID positive and we all need to isolate. Please, I'm asking and begging on behalf of the government and the Ministry of Health and other agencies, and especially our frontline staff, for us to support. Let's prevent COVID through these measures. Your second question dealt with the hotel industry. And I'd like to commend and to thank all hoteliers for their continued support. Currently, we have 7 hotels that serve as state-supervised quarantine facilities, providing support to our returning nationals. And this is a very coherent group. We also have approximately 5 hotels that serve as quarantine facilities, that is, pre-mobilization quarantine facilities for the energy sectors. And yes, they can be allowed to serve food to their guests, given the situations. However, as per the public health regulations, an exemption needs to be written for consideration to the Minister of Health, who will give that exemption to them. Once again, I would like to recognize all hoteliers and their staff for their continued support, because they also constitute part of the parallel healthcare system. And I'll say that having managed the parallel healthcare system and the repatriation process, they have been extremely cooperative and continue to support the system at all levels. So Nadine, I hope this answers your question and brings clarity. And in closing, let's avoid congregation, let's avoid commingling. We understand the population's concerns, we understand the difficulty that you are going through, and we thank you for your cooperation so far, but there's room for improvement. Thank you very much.
And thank you, Dr. Richards. We now go to IETV.
Hi, good morning. Binima here from IETV News. I have 2 quick questions. My first question would perhaps go to Dr. Hines. Dr. Hines, you received a message from a member of the public this morning. They're asking, would a PCR test be affected in the case of someone who is vaccinated? Will the vaccine cause a PCR test to be positive, or would the PCR test only show positive if the person is affected with COVID-19? My second question would go perhaps to Dr. Richards. We also received complaints from a large number of the population, and we saw in social media as well that the numbers given to make appointments for the COVID vaccination, a lot of persons saying that it is left unanswered. Now, iNews, we tried to call several of the numbers and we received the same results. And a number of persons are saying as well that the WhatsApp messages, it's being left unacknowledged. So now they are uncertain whether they are registered or if their messages went through. Any clarification? Thank you.
Okay, thank you for your first question. It's a very good one, and I've heard it a few times. Glad to be able to address it. The vaccination does not cause anyone to have a positive PCR test. The vaccine that is being used does not then create any of the viral DNA circulating in your system to be picked up by a PCR test. So whether you're vaccinated or not, the only time you will have a positive PCR test for the COVID-19 virus is if you are currently or were recently infected. So the vaccine will not change that. It won't give you a positive PCR test. So thank you for giving us the opportunity to clarify that.
Okay, thank you again for a very good question, which is quite operational. And firstly, the Ministry of Health is very, very appreciative of any sort of feedback that can improve systems for members of the population. I'd like to start by reminding persons in the population, reminding everyone that vaccines are just an additional layer of protection with regards to COVID-19. We have to continue the COVID-19 prevention measures in addition to being vaccinated. But the Ministry of Health would like to also commend the population on the enthusiasm and the high risk of vaccine acceptance that we have noted across our 29 sites. Now, we have mass vaccination sites, and this is clearly identified on the Ministry of Health's website. I would like to recognize the concerns raised about the communication system for vaccine appointments. Yes, we understand, and due to the high vaccine acceptance rates, we have been inundated with calls across all of the RHAs. We are working assiduously to respond to the WhatsApp messages and to increase the number of phone lines to return calls. I'd just like to let you know that sometimes there may be a one-day sort of gap with respect to returning the appointments, with respect to WhatsApp messages and returning the appointments. But the teams at the RHAs, the CEOs, the nurses, the lead physicians, and all others are working very, very hard and being very diligent in returning calls and making appointments for persons. I'd like to thank the population for your continued patience as we try to improve the system with respect to vaccination. And thank you once again for your high interest in receiving the COVID-19 vaccine.
Thank you for the clarification, Dr. Hines and Dr. Richards. We now go to the Trinidad Express.
Good morning, Kimbodram Express. Maybe for Dr. Abdul Richards, Dr. Carrington did offer us a breakdown of the presence of the variant. She did state that all versions of COVID-19 are dangerous, potentially dangerous, but we are seeing increased deaths among younger people in their 30s, 40s, and without comorbidities, plus the increasing presence of the variant. So maybe for clarity for the public, can we say why we are seeing these increased morbidities among younger people? Is there any connection at all to the variant? Can we clear that up? Thanks. Also, we are getting reports from people who are reliable that they are going for their COVID-19 tests, but they're being told that because of the surge and the volume of people seeking tests and the amount of tests that have to be processed, that they would have to wait up to 2 weeks in some cases for the results. And in the meantime, they have to quarantine at home. Some are saying there's no monitoring system that seems to be in place checking on them as to whether or not they are in fact quarantining at home. So can we bring some clarity to that situation as well? Thank you.
Okay, thank you for those questions. Now, as we have said before, as Professor Carrington also just pointed out, there isn't yet any concrete evidence that suggests that this particular variant is selecting or infecting younger persons in a preferred or a preferential manner. But what we are seeing is a wider cross-section of the population being affected because we have much larger numbers. We're seeing large numbers, and whereas if you only saw small numbers of cases, then the numbers of people in that young age group would look relatively small. As we have larger numbers of people affected, you are seeing that reflected in you now being aware of younger people who are also being infected and also having those adverse outcomes. And what it does is it serves to remind younger people who sometimes forget that this virus can indeed have adverse and fatal outcomes in younger age groups. It reminds them that they are not immortal, they're not immune to the adverse outcomes, and it brings it into perspective. So we are seeing more of each age group, and we're now becoming more aware of larger numbers of younger people because we have larger numbers of infected people. It's also important to note that we have larger numbers of asymptomatic people that we don't know are infected, who may be walking around and moving around and continuing to help spread virus, which is why we are asking the population in general to reduce its movement. That's the thing that's going to help us to reduce that upward trend, that exponential spread. So hopefully that explains the first question. The second question, the turnaround time for the lab, as far as we are seeing at our end, has not really changed too much. We do have that increased surge. We do have larger numbers of tests being performed. There is no instance that we have seen where a test takes 2 weeks to come back. We are seeing that time frame on which we report being 24 to 48 hours. Sometimes it may go to 72. But that's sort of the time frame in which a result gets turned around. So I'm not sure under what circumstances people are being told about a 2-week wait, but there isn't anything at the lab end that would be responsible for that. And with respect to the quarantine, there is a system in place with the county medical offices of health to follow up on those who have a positive test. But it's important to note that once you're exposed, your quarantine will be 2 weeks, regardless of whether you come back with a positive test or not. Once exposed, that quarantine period is set. So I'm not sure if there's some confusion as to why they're being told to wait for the 2-week period. But that 2-week period of quarantine is set by the public health management of the infection and the exposure to COVID-19. Hopefully that helps to clarify. Mr. Alexander.
Thank you very much, Dr. Hines. I now hand you over to Dr. Richards.
Thank you, Dr. Hines. I'd just like to provide some additional information with regards to the management of primary contacts. Now, primary contact is somebody who is exposed to a confirmed COVID case. And this exposure may occur at the workplace, it may occur in terms of some sort of congregation activities. And again, we want to reiterate that persons need to stop congregating, stop mixing, stop commingling in the interest of our population and their health. Again, the message of personal responsibility now extended across to the management and treatment of primary contacts. If you are a primary contact, please exercise personal responsibility, even if there is a gap time, 1, 2, 3 days in terms of the ministry contacting you. We have forged a collaborative relationship with our physicians within the energy sector and essential services, our private physicians who assist us in contact tracing, and we would like to thank them. But let us please exercise personal responsibility and stay at home and isolate or quarantine yourselves, if you were in contact with a COVID positive patient. Thank you.
And thank you, Dr. Richards. Time was short today, so as we close, I thank you for viewing this COVID-19 update. We hope that the information shared this morning was of benefit to you. You are reminded to wash your hands, watch your distance, and wear a mask over your mouth and nose when in public. Thank you for viewing.
In crisis situations, children can perceive anxiety, which can cause them to feel stressed. Depending on their age, their response may vary. Some may become overly attached, while others may withdraw. Some may become anxious, angry, or agitated, and others may even start wetting the bed. Here are 5 tips to help manage stress in children. Play. Encourage children to play and suggest activities to help them relax.